Module 3 presentation, Differential Diagnosis of Dyspnea. In this presentation, we will be discussing and developing a differential diagnosis for acute dyspnea in the office setting. My name is Dr. Naomi Ruth Smith, and I am a family nurse practitioner with 14 years of experience. I am also a visiting professor at Chamberlain University and an active member of the American Association of Nurse Practitioners and Louisiana Association of Nurse Practitioners. Today we are going to be discussing how to determine the differential diagnosis for dyspnea in the primary care setting. Let's start by discussing what dyspnea really is, because most patients do not present to the office saying, "I'm having dyspnea on exertion." Dyspnea is a subjective symptom from the patient that has varied meanings to many individuals, so it is important to really understand the context of the complaint. Some examples of the descriptions commonly used for dyspnea are shortness of breath, difficulty breathing, can't get enough air, breathlessness, suffocation or smothering, air hunger, and winded. Dyspnea is one of the more common complaints in primary care that can be caused by a number of diverse health problems. In the majority of cases, dyspnea is a result of cardiac or pulmonary decompensation. However, other etiologies can include metastasis, neuromuscular disease, spinal cord lesions that affect the innervation to the diaphragm, pain, and panic disorders. Complaints of dyspnea can include the following. Acute. It has an acute onset and it resolves with treatment of the underlying condition. Chronic. It is defined as greater than 1 month in duration. Chronic dyspnea can result in progressive dysfunction, severe disability, and even death. COPD and CHF are classic examples. Acute on chronic. This would include a case of a COPD patient with an acute exacerbation. When the symptom of dyspnea is greater than the expected level that would occur with exertion, it must be considered to be pathological or a symptom of disease. Establishing the underlying cause of chronic dyspnea is often a difficult task because there are many conditions that fit the bill. About 2/3 of symptomatic patients, the etiology is due to cardiopulmonary disease. In 1/3 of all cases, the cause of dyspnea is multifactorial. Common cardiopulmonary conditions include asthma, chronic obstructive lung disease, malignancy, heart failure, interstitial lung disease, pneumonia, valvular heart disease, intracardiac shunt, arrhythmias, cardiomyopathies, and myocardial ischemia. Non-cardiopulmonary causes should also be considered and include obesity, physical deconditioning, anemia, psychogenic disorders such as anxiety, depression, etc., neurodegenerative disorders such as Guillain-Barré, amyotrophic lateral sclerosis, kyphoscoliosis, metabolic acidosis such as diabetes or chronic renal failure, upper airway obstruction such as tumor, vocal cord paralysis, tracheal stenosis, etc., and pharmacological causes of dyspnea. Dyspnea can be classified into flow or volume disorders, and underlying the cause can be from an intra or extrathorax problem. Flow disorders: intrathorax, obstruction of distal smaller airway; extrathorax, obstruction of proximal larger airway. Volume disorders: intrathorax, lung parenchyma disorders; extrapulmonary disorders; extrathorax, lung compliance disorders; respiratory center disorders. Flow disorders, intrathorax. Intrathorax disorders originate from obstruction of distal smaller airways and include asthma, bronchiolitis, vascular ring, solid foreign body aspiration, and lymph node enlargement pressure. These types of disorders cause expiratory effort in infants and also in children less than 5 years of age, such as bronchiolitis. Examples of extrathorax flow disorders which originate from obstruction of the larger airways include rhinitis with nasal obstruction, nasal polyp, craniofacial malformation, obstructive sleep apnea, tonsil and adenoid hypertrophy, laryngotracheomalacia, larynx papilloma, diphtheria, croup epiglottitis, and thymus hypertrophy. Infants or children ages 5 and younger are affected, and they have clinical findings of inspiratory stridor. Examples of intrathorax volume disorders include lung parenchyma disorders such as pneumonia, infection aspiration, atelectasis, pulmonary edema, near drowning, and sepsis. These orders affect inspiratory effort. Examples of extrapulmonary volume disorders include pneumothorax, pneumomediastinum, cardiomegaly, heart failure perfusion, pleural effusion including empyema, hematothorax, hernia diaphragmatica eventration, intrathorax mass, non-pulmonary, chest trauma, rib fracture, lung contusion, and thorax deformity such as pectus, evacuum, and scoliosis. These disorders also affect inspiratory effort. Extrathorax volume disorders due to lung compliance issues include neuromuscular disorders, gastric peptic ulcer, extreme obesity, peritonitis, appendicitis, acute abdomen, physical deconditioning, anemia, psychogenic disorders such as anxiety, depression, etc. Areophagia, meteorismus, ascites, hepatosplenomegaly, and abdominal solid tumor. These disorders cause inspiratory constraint. Extrathorax volume disorders that are due to respiratory center disorders include anemia, metabolic acidosis, CNS infections such as meningitis and encephalitis, encephalopathy, typhoid, DHF, metabolic. Psychologic anxiety, usually in adolescents. poisoning, salicylic alcohol, trauma capitis, and CNS disease siliquae. These disorders cause deep, rapid breathing. Now that we know the different types of dyspnea and how to categorize them anatomically, let's talk Now that we know the different types of dyspnea and how to categorize them anatomically, let's talk about the clinical approach to establishing a diagnosis in order to guide treatment. There are 3 parts to this process: assessment of symptom, physical examination, supporting data. 80% of dyspnea cases can be initially diagnosed through history. First step, anamnesis, a patient's account of a medical history. Identify the age, sex, etc. Determine what is meant by the complaint. Acute, chronic, recurrent. The degree of the dyspnea. And how long has the patient been dyspneic? Timing of dyspnea. You want to know if they were dyspneic at rest, at activity, day or night. Triggers, factors making it worse or better. You want to consider the potential environmental exposures. Underlying cardiopulmonary neuromuscular disease. Associated symptoms such as chest pain, cough, and wheezing. Previous occurrence and response to therapy, if applicable. Clinical step 2. A complete physical exam should be performed with particular attention to the pulmonary and cardiovascular systems. The provider should approach the examination systematically, noting the following symptoms: vital signs, respiratory system, and cardiac system. Vital signs including tachycardia, tachypnea, fever, oxygen saturation, hypertension. Involving respiratory, nasal flaring, intercostal chest retraction, abdominal muscle contraction, prolonged expiration, abdominal muscle contraction, symmetry of chest expansion, quality of breath sounds, increased, decreased, or absent, present and symmetry of abnormal breath sounds, crackles, rhonchi, wheezes, fremitus, stridor, dullness with percussion. Regarding cardiac, you want to assess for third and fourth heart sounds, murmurs, friction rubs, jugular venous distension, pedal edema, and calf tenderness. Clinical step 3. Diagnostic tests should be guided from the history and physical exam and the suspected cause. Diagnostic tests: chest x-ray to rule out tumors, TB, pneumonia, and other pulmonary disorders. CBC with differential to rule out anemia and infection. Peak expiratory flow test in the office to determine the degree of expiratory airflow obstruction in patients with asthma and COPD. Electrocardiography and echocardiography. Spirometry to determine obstructive restrictive, and mixed lung disease. The end.